webinar would be of a duration of about 45 minutes, which would be followed by a brief question answer session. So as we all may have encountered headaches in our daily practice, but however, it is an entity which needs utmost care while assessing and treating. So let's hear it from our very own, the executive director of the institute, who is also the founder member, who is the pioneer of bringing McKenzie to India. She is the only faculty from McKenzie Institute India representing India at the international level. So we'll hear it from her all about the headaches and how to treat headaches the McKenzie way. Followed by her, we'll be having Dr. Hardeek, who will be presenting an interesting case. He is a diplomate in MDT and he's also a probationary faculty right now under Asha ma'am. Thank you. Yes, ma'am.
Thank you, ma'am. Thank you so much. Please.
Yes, Hitesh, thank you very much. Yes, I am the faculty, but I am joined now by the probationary faculty, Dr. Hardeek. So we are two of us now, presenting. So whenever there is any faculty meeting, we are going to be two of us who are going to be representing India. Thank you very much for your kind gesture of introducing me. Let us start without waiting, since we have quite a few participants who already started and it's already 4 minutes past 6. So we start with headache, McKenzie method of management. My first question to all the participants who are here, just answer to yourself, is headache a symptom or a diagnosis? I really do not need the answer, but just think about it to yourself. Is it a symptom or a diagnosis? Let's look now at the anatomy and physiology of headaches. What is the essential nociceptive stimulus nucleus of the head, throat, and upper neck? It's the trigeminocervical nucleus, which is here. Now, what happens is, can everybody hear me?
Yes, ma'am.
So the trigeminocervical nucleus is the essential nociceptive nucleus of the head, throat, and the upper neck. Now, what we see that along with the neurons, second order neurons from the trigeminal nerve, there's also fibers from the C1, C2, and C3, which terminate on the common second order neurons in the trigeminocervical nucleus. So what we have is on the trigeminocervical nucleus, we've got afferents from the trigeminal nerve and we've got afferents from the C1, C2, C3. So nociceptive stimulus from both these locations would be going, which gives a very overlapping pattern of the primary afferent fibers. Now what happens is, if this is the trigeminocervical nucleus, we've got afferents coming from both sides, from the trigeminal nerve afferents and from the C1, C2 afferents. And so because of the bidirectional interactions which are there, nociception from the trigeminal cervical source, so if the nociception is coming from the trigeminocervical nerve, it could very well be perceived as pain in the neck. So obviously, when the nociception is coming from the afferents of C1, C2, C3, what would happen? The brain would not be able to perceive whether the nociception is coming from the trigeminocervical afferent or from the C1, C2 afferent, and it could be perceived as a headache. So here what we see is neurons from the trigeminal nerve respond to stimulation of the afferents from the C1, C2, C3. And because of this convergence, you may get headache as a referred pain and upper neck pain. So, what does this tell us? Obviously, before we start with the treatment of a headache, before we try and put our hands on the patient, what we need to first understand is where is the source of the headache. Let's look at how, in three ways, how does the nociception arise? It could be from the terminals of the peripheral nociceptive afferents when they get stimulated. So that could be two. It could be either mechanical or it could be chemical. So if it's mechanical, it involves distortion of a network of collagen. That means that we could find that probably there are some positions, postures, movement which may affect the symptom. What happens with the chemical stimulation is that it could be because of inflammation or it could be potassium ions liberated from injured cells, for example, blood. And so if there's a headache and there's a nociception there, we need to know, is it a chemical stimulation or a mechanical stimulation before we start even looking at treatment. So the first thing that comes here is a diagnosis. What is the cause of it? Now, the second would be neurogenic pain. It requires an ectopic generation of action potentials along the course of the peripheral nerve. So the same way what I explained on the slide number 2, the causative lesion may not be in the peripheral territory, which is supplied by the nerve, but it may be as far proximal as the roots of that nerve. So it could probably be that the causative lesion is as much as far as the mid pons or the brain stem, and maybe the pain is produced in the neck. So the patient shows it as a neck pain. Or it could be that the causative lesion is at C1, C2, C3 and is being referred as a headache. And so we need to really know whether the headache is because of a lesion cause which is higher up or from C1, C2, C3. Is it chemical in nature or is it mechanical in nature? And so we've got to understand what is the type of the pain that has got to be recognized, and the source has to be accurately explored. And that exploration would come with a very robust history taking and a very thorough physical examination. Now, the third in which a nociception can arise is central sensitization. This is so often overlooked by physiotherapists in their keenness into treating a patient. I remember when I was training in NHS for my diploma MDT, I had seen a patient who had headache for 18 years. She also had pain with to her neck and her extremities. We were able to effect the pain in the neck and to the extremities, but we were not able to effect the headache. What can happen is that there is sensitization, there is a difficulty in the processing of pain, there could be dysmodulation. And so these are the patients who could be candidates for multidisciplinary treatment. Now, this has to be at any time when a patient comes to you with headache, which is on a chronic time frame. We need to distinguish and we need to alert ourselves to this possibility that there could be centralization. Sorry, sensitization. Let's look at the differential diagnosis in headaches. Now we know that before we start with the treatment of the headaches, what we need is a proper differential diagnosis. Now headaches can be of different types. It could be intracranial, it could be extracranial. If it's intracranial, it could be a brain tumor, brain abscess, subdural hematoma. Extracranial could be lesions of the eye, could be lesions of the middle ear, nasal sinuses, oral cavity. There are also other reasons for headache, which could be a meningeal irritation, acute meningitis, chronic meningitis, syphilis, tuberculosis, sarcoid, cancer. There could be cranial causes, which could be metastatic neoplasms, Paget's disease. Vascular disturbances are very, very important. It could be migraine. It could be temporal arteritis associated with polymyalgia rheumatica. It could be subarachnoid hemorrhage. Sometimes a subarachnoid hemorrhage, it might not initially be visible on a CT or an MRI. So we need to be very alert, especially if a patient has come in with a past history of close history of trauma. It could be hypertension, carotid or vertebral artery dissection. And so it's very important for us during the history taking for us to see whether there are multiple vascular risk factors in the patient. It could be toxic states, which could be infections, alcoholism, lead, and arsenic poisoning. It could be extracranial. We have already seen psychogenic conversions of hysteria, anxiety states. When this comes in, obviously there is going to be a muscle tension. The others could include cervicogenic cluster, post-traumatic, exertional, and post-coital. Now, the first thing that we've got to alert ourselves is to red possibility of a red flag indicator. It could be that the red flag indicators are 1 to 2%, but it is our caliber for us to know, to rule out, and to know what is not what we have got to treat and to be referred. So when we look at possible red flag indicators, now these are red flags is signs and symptoms that raise our suspicions for serious spinal pathology. So this could be that you find a patient who is progressively worsening. It could be that the patient has got a recent severe onset or a thunderclap headache. Let's say a patient with more than 50, 55 years, 60 years, never had a headache, never had a headache, and it's the first time headache. Raise your suspicions. Think in terms of differential diagnosis there rather than your treatment. The onset of headache could be after an exertion. Onset of headache greater than 50 years old. History of a major trauma, nausea and vomiting. Now, history of a major trauma, always be careful, even if it is 2 months post trauma. Be very careful before you put your hands on. We've got to check the patient out thoroughly using positions, movements before we put our hands on the patient. There could be nausea, vomiting, associated nausea, vomiting also, be very careful. Temporal and occipital headache with visual changes. These are things to be careful about. Preceding sore throat and respiratory infections. In our clinic, if you have a patient who has got a preceding sore throat, respiratory infections, and they come to us as a follow-up or as a first time for even neck pain associated with headaches, we do not see them. We put them off for another appointment after they have sorted out the respiratory infection or the sore throat. History of cancer, problems with speech, swallowing, visual changes of diplopia, ptosis, blurring, associated symptoms of progressive weakness, convulsions, blackouts, mental changes, they are systemically unwell. These are things that you've got to be very careful. Now, this is a paper which is ahead of print. Finucane et al. It is being published online on May 21st, 2020. I happened to get the paper. International Framework for Red Flags for Potential Serious Spinal Pathologies. Now, look here what it says. Spinal surgeons, so this is what I have copied from the paper. Spinal surgeons likely to see more cases of serious spinal pathology than general practitioners do. And physical therapists probably see a number in between. That means we as physiotherapists will be seeing somewhere between the spinal surgeon and the general practitioner, depending upon where they are on their clinical pathway. This itself is a very indicative thing that tells us that we need to rule out a serious spinal pathology before we start treating the patient. Now we know that successful management of any headache disorder lies on accurate differential diagnosis. Now this is ridden with difficulties. Differential diagnosis in a headache is very difficult. The reasons are limited validity and reliability of the classification criteria. And so now there is a classification criteria which is by the International Headache Society. So there is a limited reliability and validity. Now, there are several overlapping features between the cervicogenic tension and migraine headaches. So when there are overlapping features between 2 or 3 different types of headaches, it becomes difficult to really have a diagnostic criteria between as to which one of it is. More than one set of diagnostic criteria are met with by the same patient, but in more than one set of diagnostic criteria are met with by the same patient in between cervicogenic tension, migraine, and other. So you will find that a lot of patients have got symptoms which look like cervicogenic, which look like tension headache, which look like a migraine, or into other. But at the same time, although there are these significant differences which are there in the diagnostic features of these headaches, yet you will find that very few features are reported solely in one type of headache. So these are the difficulties that we encounter when we try to do a differential diagnosis. So as we said about the International Headache Society, the extensive classification by them is very lengthy. So it's got to be any classification system has got to be simple. It's got to be and this is detailed, and it's very inconsistent. It is also not easily available. Now, any classification system should be easily available, and it should also be easily taught so that other clinicians around the world can replicate it. Now, this is not possible because this has been published in a specialist journal and people cannot be taught on it. It's also based on systemic disorders and external factors. Now, it's also based on structures and pathophysiological processes, which are very poorly understood in chronic benign headaches, because we know that pathoanatomic diagnosis may not really hold good for sometimes when it is mechanical in origin. Now, there can be lack of empirical findings also, because large part of this work which is done and published is based on expert opinion and consensus. Now, most of us, what we treat as a physiotherapist is a cervicogenic headache. So when we have done a differential diagnosis and we come to the diagnosis that this is a cervicogenic headache, that's where we come into the picture and we would be treating them. Let's look at what is the differences and inconsistencies which are there, which is in the diagnosis by various groups. So one is the location of pain. So various groups have got different opinions upon where the location of pain should be. Also, whether it should be unilateral or bilateral. So there are inconsistencies, and they do not come up on the same table on whether it can be unilateral or it will be bilateral. Also, whether it can change side. It means on one time the headache is on the right side, then the headache can change side and come onto the left side. So these are not really they have not really consistently come up on a table, and that these are seen as differences. So they do not, even the positive response to nerve blocks, would they really respond to nerve blocks? Will a cervicogenic headache respond to nerve block? There's one set of opinion that they could, and there is another set of opinion that they may not. Also, the radiographic criteria, there are differences on opinion for that. Stipulated neck trauma and abnormalities in the local muscles or some of it. Also, what are the additional symptoms that a patient can have with a cervicogenic headache? Like a patient with a cervicogenic headache, can they have arm symptoms too? Or can they have dizziness? So even these additional symptoms, there are differences about this by various groups. Now let's look at, but there are consensus too. And so what are the consensus and what are the difficulties on diagnosis of cervicogenic headache? The consensus is that everybody decides that it starts around the occipital area. That's one thing where everybody agrees to. Also, that is aggravated by neck movements. So when you move the neck into different movements, you might find that there may be an increase, decrease, abolished. It could also be that there is a decrease in the cervical range of movement. But again, here, there is a decrease in the range of movement, but it may be so small that it's not perceptible. That means when you start looking at the patient and physically examining, you would feel that the range of movement is full. But if during the course of the treatment there, the headache is abolished and you happen to recheck the movements, you will find that there has been a greater movement now after the headache is abolished. So that means prior to the headache being abolished, the movement loss that we saw, there had been a small movement loss. Now, the difficulties could be that there could be overlapping symptoms from the migraine and tension headache. What is the area of symptoms in a cervicogenic headache? Very frequently, it is symmetrical. It will be the occipital region, the frontal lesions, the temples, the orbital regions, vertex or the ear. It can be accompanied with dizziness, nausea, or photophobia. Let's look at migraine versus cervicogenic. When we are looking at migraine, you might find, now you see there's a lot of similarities. Cervical pain may be greater than nausea and vomiting in a migraine. In a cervicogenic, secondary to neck pain, the headache can be secondary to neck pain. It could be primary with no neck pain too. So you see in both migraine and cervicogenic, you find that there could be neck pain. A migraine can have a decreased range of motion in the cervical spine. And at the same time, in cervicogenic, also you find that symptoms associated with consistent activity or sustained postures, there may be a small loss of movement. And it may be a small loss which may look as though that there is no loss. So it's so small that is not perceptible. Cervicogenic, it will be intermittent. Now, if you're looking at tension type of headache or a cervicogenic headache, the tension headache may be linked to cervical spine, and cervicogenic headache may be secondary to the neck pain. It could also be primary with no neck pain. So cervicogenic headache can be primary or secondary to neck pain. That means the patient can come to you primarily with a headache, or it can be that there is a neck pain and secondary is a headache. A tension headache also may have a greater forward head posture. That means you're going to find that there is a change in the cervical range, because if you are going to be putting your head posture into one position for a long time, then there is going to be a loss of movement. So there is a decrease in cervical range. In a tension headache, exercises and education are known to help. But in a cervicogenic headache, they are intermittent. The symptoms are associated with very consistent activity or sustained postures. So this is what you are going to understand from the history taking. Let's look at, so in the light of the above information, we know for one thing, we need to understand where is the source of the headache. Is it coming from the cervical spine or is it coming from above? So where is the source? Now, if you know that the source is cervical spine, we need to know whether it's chemical in nature or is mechanical in nature. So now the diagnosis or differential diagnosis is ridden with difficulties. So considering all this, the question of the hour is, should we learn to manipulate headaches or should we learn to diagnose headaches? So let's think of what is your safety blanket. If you think in terms of putting your hands on the patient very quickly, what's your safety blanket? Can we give a valid reason to the medical doctor to manipulate on a headache patient? So we need to really think about how we have evaluated the patient, how have we done the history of the patient, how have we done the physical examination, have we ruled out the red flags, post which how safe is it for us to put our hands on the patient, and which is the right time to put our hands on the patient. Let's look at how do, as a MDT clinician trained in the McKenzie concept, how do we look at headaches? Headaches, whether they are primary symptom or a secondary symptom. That means the patient comes to you with just a headache and he's come for the treatment of just the headache. The secondary is where there is a neck pain and the headache is secondary in nature. We are going to, in both the conditions, we are going to rule out the red flag first. So the primary important thing here is ruling out the sinister pathology. Now, if headache is a primary symptom, since this webinar is more about headache, we are looking at headache as a primary symptom. Once we exclude the red flag, what we would do as a McKenzie trained physiotherapist is we would determine if the headache is cervical in origin. That is, once we know the red flags are ruled out, next is the headache coming from the cervical spine? Now, once we know that it's coming from the cervical spine, is that headache coming from the spine which is mechanical in origin? That means there could be positions, there could be postures, there could be movements which will affect the headache. We are also going to determine if there is a presence of a directional preference. Now, those of you who do not know what's a directional preference, I would ask you to go on to the McKenzie Institute India YouTube. And we have a couple of videos there. And there is one particular video which is an overview on extremities by Dr. Devang Dharak. You could go and look at that and you would probably get more answers on what's a directional preference. So we are going to see if you're going to get a directional preference there. That is one movement which is going to affect the symptoms. One direction which could be a movement or which could be a position. We are going to determine what is the mechanical diagnosis. That is, we are going to mechanically diagnose and classify. So what is the subgrouping of the patient who has a headache? And then we are going to proceed with the appropriate mechanical therapy. So in the history, what we do is first map the symptoms. Once we map the symptoms, it tells us, it starts with our provisional classification. We also look for the check for the presence of dizziness, nausea, tinnitus, visual disturbances, difficulties in swallowing, drop attacks, loss of consciousness. We look at the vascular risk factors of the patient, what's the past history of the patient. These are very, very, very carefully seen and questioned. Once we were to get all these and we've ruled out a red flag, we would also look into the better worse session, into looking at the clues, try and find out from the history to the mechanical nature. So that's all a part of clinical reasoning that is taught during the courses in terms of when they do their A to D and their credentialing examination. We check to see whether is there any mechanical markers in the history. Is there any position, posture, movement or an activity that is making the patient better or worse? We are also trying to see, is there any consistency? We would also see what is the nature of what is the onset of the patient? Symptoms of headache. What is it intermittent? Is it constant? Which once again gives us a mechanical marker. Because if it's a constant pain, then we need to also think more in terms of, is there a chemical nature to it because it's constant? Is there any red flag indication there? And it's also, even if it's a constant headache, and even if it is mechanical in nature, we know here that there is no position, posture, movement, which is affecting the symptom. So very carefully, we are going to be like Sherlock Holmes, looking at the various questions that we are going to quiz the patient and try to get to understand what could be the hypothetical diagnosis at the end of the history. Once we come to the hypothetical diagnosis, we are going to decide on how we're going to take the physical examination. How extensive should our neuro examination be? Should we even the question of should we even physically examine the patient, or should be referring the patient straight off? This question is also answered by us. So we are going to, in the physical examination, we are looking at pain status at rest. We are looking at effect of posture correction. So MDT is the only evaluation tool which checks what is the effect of the symptoms post posture correction. So this is carefully looked at. Repeated movement testing, once again, MDT is the only evaluation tool which looks at repeated movement testing. So this is like a litmus test to us, which tells us and helps us to classify the patient and diagnose the patient. And so at every level of the examination, we are going to look for a change in the baseline symptoms and movements. A very good thing that's done for every headache patient is you have got to remember to check the blood pressure of the patient. Sometimes it could also be that the pressure is low and the patient has got a headache. There has been several times where we've come to the physical examination, and the moment we have checked the blood pressure, we've not needed to do anything else, and we have sent the patient off and asked them to meet their physician and re-evaluate their blood pressure medications. What has to be very importantly done is also a neurological evaluation, and the extent to which you're going to do it all depends upon the history. Also, when you're looking at the physical examination, we are going to be looking at movements, overpressure, movements with overpressure, or we are going to look at sustained positions. So if it is mechanical, that is we as physiotherapists can treat them with exercise. The symptoms will localize to the occiput. It will change size and increase the mechanical responses. The mechanical origin is confirmed then by us. So we would classify as derangement syndrome, dysfunction syndrome, postural syndrome, and other. So the classification goes very simple here, and around the world, it is easy to follow because there are educational systems that are teaching this. So on an evaluation, if with the repeated movements, with the static positions, if you're getting a rapid abolition to the symptoms and you get a directional preference, that means we identify a loading, a movement, or static forces that are needed. We see that there's an increase in the range of movements to repeated movements or sustained postures. We see that the headache has got abolished. And in these types of headaches, always remember, once it's abolished, it's not very easy to reproduce it. And we see that there is a limitation of movement, but we have seen that post-abolition, there has been an increase in the movements. Then we would diagnose this as a derangement syndrome. So this would be this sort of a patient who on an evaluation, we would get these results. We are going to classify them as a derangement syndrome. Let's look at what is going to be the management of this. The management would be a reductive exercise. That means the reductive exercise, we have a directional preference. That is one movement or one position in that particular movement, which is going to reduce the headache or abolish the headache. So it could be the reductive exercises, could be movements plus positions. There would be a directional preference here, and we would do progression of forces as and when indicated. So the progression of forces would be where we would then want to put our hands on, but that would be indicative. How would it be indicative? Now we have, so the progression of forces is the hallmark of MDT. We would first complete the patient generated forces. The patient is going to use the positions, the movements which are in the directional preference. He would exhaust it till he plateaus out and there is no further improvement. That is when we are going to start with the clinician generated. That is where we are going to put our hands on. How we are going to decide it? This is going to be decided by based on the terminologies in testing and the directional preference. So when we go on from the patient generated forces to the clinician generated forces, we have a safety plan there because the patient has done hundreds of movements. We have tested the faulty structures there. And so when we are putting the hands on, we are absolutely safe. We know that that's the movement that we need to do. Once again, in the clinician generated forces, we would not go to the largest force of manipulation. We would go by the least force first. So we would go on to clinician overpressure, mobilization, followed to manipulation. And this would be what we would use directional preference as a direction for us. What is the manual therapy we are going to be using? Which is the direction we are going to be using? So it's not going to be one size fits all headache patients, the same manual therapy. We are going to be changing our hands on depending upon what's the directional preference we are getting. Let's say we on evaluation we have a history of trauma, we have a surgery, we have past history of derangements, we have, and consistently the headache is produced at end range, which goes off immediately as soon as he comes off, and it does not really affect other movements symptomatically or mechanically. Now, this is where we are going to be diagnosing and classifying this patient as a dysfunction syndrome. So, what we need to do here is a remodeling. All that we need to do here is the headache is caused because of remodeling. And all that we need to do is educate the patient that this is going to take time. Remodeling anytime takes time. Your post-operative supracondylar fractures or your any of the post-operative where they've been in a cast for a period of time, you know it takes time. So this is where a headache is due to the need for remodeling. How would you do it? By remodeling exercises in the direction which is confirmed on repeated movement tests. So once again, it's not just all movements. It's going to be very specific as to which is the direction, which is going to be told to us during our physical examination of repeated movement test, or also with using the positions. So in this, we do not need to really use our hands on the patient. Let's look at another position where a situation where on an evaluation you get patient's headache is clearly affected by posture in history and physical examination. There's no loss of movement, no effect to the repeated movement. This is more because of a postural syndrome. As soon as you have corrected the posture, the headache is gone away and doesn't really come back. And this, the patient really doesn't need any treatment. All that he needs here is absolutely no hands-on, no modalities or no ECGs, no further investigations. All that we need to do is a patient education, and it's the patient's responsibility. And so we need a very strong patient education there. And so we know that for a headache, we are going to have situations where we are going to be having a directional preference and we use our hands on. We are going to remodel. We don't use our hands on. We are going to educate the patient. We're not going to use our hands on. We might refer, not use our hands on. And so, question of the hour, headache, should we manipulate? Is it a symptom or a diagnosis? Is for us to answer. Let's look at mechanical diagnosis. It's a safety blanket that helps us to diagnose the mechanical nature of a headache. So we know that not all not all headaches are red flags, but it is very essential for us to rule out the red flags in every headache patient. They may be 1 or 2%, but we need to rule them out. We need to rule out other causes of headaches before we start treating them. Thank you so much.
Thank you, Dr. Asha Menon. May we now request Dr. Devang Harek
Thank you so much, Dr. Rich. And well, I am audible.
Yeah.
All right. Thank you so much. Yeah. So I start with this presentation. And continuing our headache theme, thank you so much, Asha ma'am, for highlighting us with in-depth knowledge about headache and various possible causes. Uh, I remember about this case, which I'm going to share with you all. This was somewhere in 2014, and all I can say, this was an eye opener for me. When we look at mechanical diagnosis and therapy, or McKenzie therapy, what we commonly call it as, is a system of assessment and management which utilizes various postures, positions, and movement, because it has been highlighted way back in 1987 by Quebec Task Force or Spitzer et al., which says that we are confined to, or most of our pain are due to activity, are called as activity related disorder. And that's why what McKenzie found out way before that was that many of those problems are due to certain postures, position, and movement. And what we do with our assessment is we subgroup those patients or classify those patients into various subgroups, and those classification would guide us with appropriate management. A simple way would be, do we keep this patient with us, do we use manual therapy, or do we use remodeling, or do we refer it to a specialist? That is what a classification does. In short, as ma'am highlighted, it's not a recipe, neither it's one size fits all. So let's look a little depth into this case all about. This patient was somewhere in his 40s, came into directly to me, and I'm sure most of us are into direct contact practice here in India. So one of the important role when a patient comes directly to us is to always follow a diagnostic triage or a classification system where the primary role of a clinician should be ruling out a red flag or something serious. So this case came to me, and his age, as you can see, is a 40-year-old person, where his work demanded more of a desk-bound job, where 80% used to be sitting work. So the mechanical stress were more of sitting, a desk work. During his leisure, he was quite active, and he used to perform morning walk. He used to also go to play cricket many a times. Well, with this recent episode, he has been quite off work. Now, that tells us someone who's off work because of headache could be either something is serious or something is which is to be looked into quite in depth, or it also at times it could be due to mechanical problem. Patient could be off work, but it also tells us about the seriousness of the condition or a severity of the condition. Also, it is an important outcome indicator for us. When you look at a VAS score, it is somewhere around 4 to 5, which is a moderate amount of pain. When we look at a body chart of this patient, you can see the head and the neck symmetrical and also symmetrical type of headache, which is occipital, temporal, frontal, everywhere, peria covering every head. When we look at a history, the present symptoms where patient had a neck pain, headache till the eyebrows. Now you can see it is there since nearly roughly around 2 weeks, which is a subacute phase. The one of the most important part of the assessment is what was the status of the condition. It was worsening at that time, which tells us someone worsening, especially with the headache, you would be very cautious with your examination. Also, you would be quite selective with your examination. And always remember, if any condition which is worsening in nature, especially with the headache, think something else other than mechanical perspective. All right. He said that it commenced while playing cricket. Now, as such, when I asked him in detail, it wasn't like where he had an injury or where he had a fall or ball hitting him on his head. Yeah, we would straight away think of something else. But it was just while playing cricket, he started off with a headache. And the symptom of onset were directly at neck and headache. You can also say it's a constant symptom. As ma'am highlighted, If it is a constant symptom, especially with the headache, you should also think of something which is chemical in nature or something serious in nature, which can give rise to this type of constant symptom. Remember, it could also be a mechanical pain. But there are two important things, which is one is worsening, and if it is a constant symptom, remember, we have to be examination, and it also tells us we need to conduct a thorough neurological evaluation. Now, as an MDT clinician, we would also look for a worse better section. Worse better means we are looking at, is there any directional preference or is there any particular load which we would explore? Now here you can see the list of things which had been worsening him. Whole lot of list, which is bending, sitting, turning to the either side, looking up, morning as the day progresses, when he's moving around, coughing. So most of the activities are worsening him. While when we look at a better side, is there anything which made him better? Was just when he was lying down or when he was still, when he was not moving. Once again, that makes us think that in worse better section, was there any directional preference? No. Was there any load that defined us? Yeah, there is something, he's feeling better when he's unloaded, but he also feels better when he's still. So that makes us think, is there any particular thing which is a mechanical or is it a non-mechanical? We need some more detail, and we would be once again quite careful with our examination. So patient had virtually no disturbed sleep, and in past he never had this kind of neck pain or headache. Remember, when we look at an epidemiological triad, most of the neck pain or headache are in an episodic manner, which would again highlight a mechanical nature of a problem. But here, someone comes to you with such a severe headache, neck pain, no previous episode, should also make your mind alert and should make you think, is it something different or is it something I encounter daily? Not likely. He was under some treatment where he was under some medication, some massage, and he was quite resting because he was off work. Once again, remember, medicine, massage, rest having no effect, especially medicine having no effect, should again pinpoint you something else. Remember, always ask specific question which with patients with neck pain or headache. And here it is very important for us to rule out 5 which, like I asked, patient had a positive dizziness and also tinnitus. Well, dizziness, tinnitus could also be present in something which is a mechanical, but it also highlights more something which is non-mechanical in origin. Here, that would also make you think about, is it a cervical artery dysfunction or commonly called as a VBI, vertebrovascular insufficiency? Or is it something to do with the higher centers? All right. Remember to check gait and upper limb. Why? Because if it is a headache, sudden onset, worsening, we should also think, is it something to do with stroke? Or is it something to do with a brainstem lesion, which was quite normal out here? Patient was already under some sort of medicines, which is like a painkiller and which had a no effect. Overall, his health was good. But at the same time, remember, he was also feeling a lot of weakness after this episode and he was quite irritable. Yeah, headache can make anyone irritable. But here he was also feeling weakness, right? Also, any patient comes to you in your OPD with a headache, ask them, are there any signs of seizures or have there any history of epilepsy? Or are there any vascular history like a very high cholesterol or someone who is a very high diabetic? That would all fall into vascular history. Or there are any visual changes as mentioned by ma'am, or are there any facial weakness, because here we are also looking for any hemiplegia or paresis or any sort of even facial palsy or Bell's palsy. So at the end of the history, our hypothesis was, is it something mechanical? Maybe less likely. Or is it non-mechanical? Seems to be more likely. But let's do a cautious physical examination. Remember, if you are not sure, at the end of the history, refer the patient to the respective doctor. But here, I went ahead with my physical examination cautiously. And on examination, I found the posture was quite poor. With the correction of the posture, it had no effect. Remember, everyone talks about posture, but the difference between MDT clinician, what we look here is the effect of posture. Is it something with correction of posture, the symptoms are reducing or are they aggravating, which would again highlight us towards, is it a cervicogenic or something else? And if it would have been reducing or something else, we would, our hypothesis towards the cervical spine would increase, but here it had no effect. Once again, makes you suspicious. We did a thorough neuro evaluation. Remember, not only for the upper limb, but we also conducted a neurological examination for a lower limb, because we are not sure that if it is something to do with a higher center, it can give some problem even in the lower limb. And you saw everything was normal. Also remember, if neurological examination is normal, doesn't mean you're ruling out red flag, because maybe in the initial stage, this may be normal. All right. So never get biased. When we looked at the movement loss, now see the striking thing. We saw protrusion, flexion, retraction, extension, lateral flexion to both sides, rotation to the both side, and there were, see, strikingly, there were nil loss. Yeah, even in cervicogenic headache, as ma'am mentioned, there could be a nil loss. But here, looking at the history and looking at here, it makes you think, is it a cervicogenic? Let's find out. And every moment, it increased the headache. Also, what we look from the moment loss section is there any direction which we would start moving our patient into or not? So, as repeated movement testing is a litmus test for us, what I made the patient do was, first we took a pre-test symptom, which were neck pain and headache till the eyebrow. We started with repeated protrusion, because most often we all are into sitting. As the patient has more of sitting work, our neck is into more of protrusion, and there was absence of any direction which we would start working with. I started with protrusion, and we saw, as I kept repeating protrusion, the symptoms increased in the head, and which was worse after that, and there was no change in the mechanics. So I tried the opposite movement. If there is something which can be increased, can it be decreased? But no, to the contrary, the opposite movement once again increased and it worsened the symptom. That sounds quite atypical. Doesn't sound like more like to do with a mechanical cause for the neck. So what we did was, with repeated retraction, then I went to repeated flexion. It has been said that when a patient is getting worse and you cannot find out any movement, you go with the repeated flexion, because what happens, it adds more stress to the upper cervical spine, especially C1, C2, C3. And here you can see that the contrary, once again it increase and worsen the symptom. Now remember, patient is already irritable with a headache, and repeated movements are steadily worsening his headache. That tells us, let's stop with the examination. So also, in repeated if repeated movement testing is steadily worsening, you should also conduct a static test, because many of those headaches respond to static test. But here, patient could not perform more than 1 minute because there was worsening of the headache. Once again, there were no mechanical changes. So on day one, it told me that this doesn't sound to be anything to do with our mechanical cause. So here, my question to myself was, is headache cervicogenic in origin? Sounds to be unlikely, though cervical movements are increasing. We really don't know. We are not sure. Is it a mechanical in origin? Doesn't seem to be as of today. Any directional preference? No. What's our mechanical diagnosis? As of we highlighted, it is others as of today. Now, what would be our therapy for today? Would be better education. What we advised to the patient was to keep his neck in neutral position and avoid any end range movement, because we saw with end range movement there was a steadily worsening. Also, remember to tell your patient, if there is no change or if there is steadily worsening of the headache, you need to see the specialist. For this patient, we kept a follow-up within 24 hours, because this is very important, where if patient is steadily worsening with everything, you need to see them within 24 hours of session. Patient came next day, patient was still the same. We did a reassessment and it was just like day one. Now, it was very strongly suggesting me on day two that this seems to be non-cervicogenic in origin. Let us, or non-mechanical in origin, let's be specific. So the best thing was I referred to the specialist to determine the actual cause of headache. So the patient went to neurologist. Patient went through series of tests, which was X-ray, MRI for cervical spine, and also remember the neurologist conducted MRI CT for brain. What MRI revealed was there was some bleeding in posterior cerebral artery due to some tear of some fibers. Now remember, I as a physiotherapist never thought of something like this, of intracerebral hemorrhage. But what made me think was that this seems to be something atypical. And remember, the crux of our system or MDT system is directional preference. And if you don't find any directional preference, especially related to the headache, you need to refer them. Identifying the cause of the headache is a part of a specialist, not us. But identifying which patient to refer is our job. And as ma'am mentioned, that a physical therapist comes somewhere in between of a specialist and a GP. Later, the patient was admitted into the ICU and kept under the continuous monitoring for 1 week, along with certain medication. You can read your mannitol and vitamin K. Consideration was also given to blood patch or surgery in case if things would have been worsening or if there would have been no reduction of the symptom. What happened was with patient responded fantastically well with the medication and eventually headache subsided within around 70% within a week and patient was happily discharged. There was a complete resolution of headache within 2 to 3 weeks time. At the end, remember, what I learned from this case was that we have an excellent screening. We are an excellent screener. We have an excellent screening tool. We are able to timely identify who would respond to mechanical therapy, who would not. Well, I myself being a manual therapist, this case told me that should I put my hands on or not? Because even if, let us say, if I would have put my hands on to this patient, the important question what would have came to us is only the people who put our hands on is we. And we know that the something which has happened to the patient is not due to us, but we could have been easily blamed for putting our hands on to the patient. So remember, we need to timely know when to put hands on or when to not. So that's why MDT is an excellent screening tool. And as he rightly said, we all learn from our patient. And so I learned from our patient, from this patient. Thank you so much. And over to you, Dr. Brijesh and Dr. Hitesh.
Thank you, Dr. Devang, for that insightful case study. I would like to once again thank Asha ma'am for a very insightful session on headaches. So just to put to it that every clinician must remain alert to the potential clinical indicators that require more extensive testing rather than that are offered by a routine clinical examination. Like ma'am mentioned, there would be some cases where the patients would require a thorough neuroeval. There would be some patients where you would just refer them straight away. So we just need to be alert as to when to go ahead or when to just refer. That was a very insightful session and something really which has opened up a lot of new things for us. Thank you, ma'am. Thank you, Devang.
Thank you, Hitesh. So do we have any questions?
So if there's any questions, we can just answer them.
Yeah, ma'am. There are a few questions. I've also put a survey on the chat box. If everybody could go there and fill in that survey for us, please.
Thank you, Dr. Devang. It was a wonderful session. Great knowledge sharing by you. We are also very thankful to Dr. Asha ma'am for a awesome knowledge sharing session taken earlier. It was great learning, and we learned a lot of new things regarding MDT treatment for headache. Thank you to all of you who
Thank you,
have been
Dr.
here
Brajesh.
and participated enthusiastically in this. Thanks a lot.
And the first question was from Anuradha.
Yeah,
Why
any questions?
why do we keep the patient on hold in case of respiratory infections?
Why do we keep the patient? I didn't get the question.
Hello,
Yeah, I didn't get what's the question.
is Anuradha online? Come to this again.
Why do we keep the patient on hold in respiratory infection? I
Yeah,
mean, I mean, respiratory infection.
I don't know what was the relation between that.
Oh, I guess I
Uh,
said in terms of sore throat, not respiratory infection. When you're talking about respiratory infections, it would be, you're talking about respiratory infection, can be pneumonia, it can be eh, n number of respiratory infections. What we are looking at is very specifically things that are related with the throat. When a patient has had, let's say, a preceding sore throat or an infection at the throat, laryngitis, pharyngitis, and so we could, the patient because of that could also have headaches, could also be that the ligament cervical, there is an infection there, and the neck is very close, and so the ligaments of the neck are also very close. So we really want to be a little careful. We do not want symptoms to overlap, and so it's best and safe for us to let that infection subside and then start with our treatment. So what we can do is get the patient to continue with whatever. If the patient is on a follow, they can just continue with their exercises, monitor their symptoms, and come back once that's better. So I'm not talking about respiratory infections, but when you look at respiratory
yeah,
infection, it involves a whole lot of things. It's just the throat.
yeah, that
All right. Yes.
answered Anuradha. Another question was some say that temporomandibular dysfunction also contribute to headache. Can you
Mhm.
light on this?
Temporomandibular
Dysfunction.
dysfunction. Now it all depends upon, uh yes, where a lot of people where the temporomandibular joint, the TM joint, where a lot of dentists tend to refer patients with TM joint pain for ultrasound. And very often I have seen that these patients very often would get better when we screen that cervical spine. Sometimes it can be the temporomandibular joint itself, and when we do a MDT evaluation, we can find a directional preference there too and use specific movements for the TM joint to resolve it. So a lot of pain in the temporomandibular, because we know that what's the nociceptive source for the TM joint area also. So you are going to have pain which is going to be referred from all these areas. But very unlikely that a TM joint is going to cause a headache. And when you talk about dysfunction, TM joint dysfunction, I would say that dysfunction is a word which is used in what context? I would look at dysfunction in terms of something which needs remodeling. So if you are looking at dysfunction in terms of remodeling, or are you talking about dysfunction in terms of where you're going to be rapidly getting a movement, a directional preference, which will resolve the symptoms either from the cervical spine or from the temporomandibular TM joint? I hope that's a useful answer.
Yeah, very much, I think. Another question was how can we go about the treatment for migraine? Is it a complete red flag?
Migraine would be more, as we know that there are vascular reasons for it. And so if it's truly a migraine, then we won't be able to effect it. We won't be able to really treat it. But because there are these features which are overlapping. So often I have experienced that there has been patients who have been labeled as a migraine and have been taking the migraine treatment for a long period of time. They happen to come to me. And so at the start, I would tell them that, look, you've been diagnosed as a migraine. If you are truly a migraine, I would not be able to help you. But if I'm going to be able to get a directional preference with a movement or a position whereby your headache and your migraine gets affected, and you've got to come to me when you have the headache. And at that point of time, if it gets affected, then it's not a migraine. So that means there has been a misdiagnosis there. For the simple reason that there has been overlapping of symptoms, differential diagnosis is difficult. And so the patient is actually not a migraine. So there has been times where, that's one of the best things that I got, that when I did my first McKenzie course and I finished my part B, which is the second level, a lot of my patients who came to me with headaches, they started resolving because a lot of them had been on medications for a long period of time and they had been misdiagnosed as a migraine. And I know that if it is a migraine, I know I can't help them. But if I can help them, it means that that's been a misdiagnosis there. So I hope that's answered.
Yeah, very much, ma'am. Thank you. Uh, Please let us know what do you exactly mean by directional preference. Ma'am, did you?
Yes. What do you mean by directional preference? So I think this must come from a participant who has probably not heard any of our original webinars. Well,
Can I just?
directional preference is widely researched upon. It's a part of the McKenzie method of treatment. Roughly around 74 to 80% of patients who come to any one of us in our OPDs will have a directional preference. That's what research has suggested from 1990 till 2020. And so what is it? It's that we have seen when we do a physical examination and we do a repeated movement test, which is once again a hallmark of MDT. It's a litmus test which tells us how do we classify the patient. We find that there is one direction of movement or position which can, in the appropriate loading, which can make the patient better rapidly or centralize the patient. And we know that when we get directional preference, very often the opposite movement is going to worsen the patient or peripheralize that patient. I hope that is an answer enough.
Thank you, ma'am. I would just like to. Hello. There are a lot of questions coming up. We would just would be able to take a few more, and then I would like to request the other participants to please put to email the questions to the institute, and you would be getting the replies through the mails. We just answer a few more questions. What about myofascial referred pain? This is from
So,
David Arun Kumar.
right. So if it's so we know what's where does the reference for a headache come from? We did that on the first, second, third slides. So if it is a referred pain and the headache is referred from some other, that's exactly what we said, is we've got to know what is the cause. Where is the differential diagnosis coming from? So if we are going to be understanding from our evaluation that this is a pain which is referred from any other location other than the cervical spine, we may not be able to successfully handle it by doing any sort of hands-on on the cervical spine. Now, if it is a pain of the fascia, once again, I would need more information about that. What's the location of the pain? How do you know it's the fascia? Whatever is the location of the pain, if I am going to be able to classify them into either I'm rapidly being able to reduce that pain with a particular position or a movement in the appropriate load, then I would classify it as a derangement of that particular joint, whatever. We know that muscles and fascia can be affected when there is some causative factor at the joint too. The muscles would go into a spasm when you have a problem at the lumbar spine or the cervical spine, which is mechanical in origin. So I'm going to be seeing the fascia pain that you have. Is it going to be resolved either rapidly, then it's a derangement. Very unlikely that it's going to be a dysfunction unless and until you have a trauma and there is some tightening of some tissues, then that would be remodeling. Or it would come into the other category where probably it could be also chronicity, sensitizations. So we need to really know, evaluate, and try to classify it and then treat it. All right.
And there's an interesting question. Uh, there was a video on YouTube where a sinus headache and nasal congestion was relieved by an MDT. Can you please explain about that video?
Are they talking about a video by Dr. Vikas Agarwal?
Yeah, I think so, ma'am. Yeah, this
Yeah,
is
Right.
ma'am, seems to be that same
One
video.
Right. So I would like to first tell you that Dr. Vikas Agarwal is an internal medicine doctor. He is an MD. He's not a physiotherapist. He's an MD and he is practicing in the United States. But along with being an MD, so he gets patients with abdominal pain, he would get patients with chest pain, and he is very eligible to do an electrocardiogram or send the patient for sonography. That's because he's a medical doctor. So he's extra qualified with McKenzie system. So he's also done the mechanical diagnosis and therapy and he's certified himself. There are a lot of doctors who have done the McKenzie courses because it is mechanical diagnosis. So Dr. Vikas Agarwal, when he has seen this patient, he has first seen this patient as a medical doctor. So he rules out this as a medical doctor. When he sees that as a medical doctor, he sees that the patient is not responding to medications, the investigations, the clinical diagnosis does not really go hand in hand. That's when he puts his McKenzie hat on and does a mechanical diagnosis on the patient. And that's when because he's trained in the mechanical diagnosis and therapy, he would then look and see, because as a medical doctor he can find nothing there. He uses his mechanical diagnosis and therapy knowledge and he does a repeated movement testing, and he has seen that a lot of patients have responded. So we cannot do what he does. And in the words of Dr. Vikas Agarwal, I can tell you what he has said is MDT, or mechanical diagnosis and therapy, also called the McKenzie concept, is not really, just for physiotherapists, or it's much beyond the scope of physiotherapy, is what he said. Because if you see Dr. Vikas Agarwal's videos, you have also seen a lot of abdominal pain videos. But if I get an abdominal pain patient, I am not going to evaluate that patient. I am going to first refer the patient, because my primary thing what I need to do is it coming from the abdominal organs, and I am not qualified to treat that. I'm not even qualified to diagnose that. So I am going to be sending that patient to my medical colleagues. Once they rule out the patient and they say that's fine, that's when I would come into the picture. So I've had times where I've had my medical colleagues uh, who has had patients with abdominal pain, and they had done a CT, they had done a sonography, they had done a whole lot of things. The patient was not responding, and then they referred, can you just diagnose the patient and see where's this pain coming from? Is it from the spine? And that's how I got results with all of them. But the patient belongs to the medical doctor first. So Dr. Vikas Agarwal is a medical doctor. He's an MD, specially qualified in MDT. And so, yes, he's got results. And I think on the 2017 conference, we were very lucky that he was visiting India. And so we invited him, and we also invited a lot of medical doctors during that conference just to hear Dr. Vikas Agarwal. And he happened to see a few patients. And one of the Part D participants, who is now a credentialed McKenzie therapist, I think, she had this recurrent sinus thing, and he said, okay, come up and let's see. And she had been on medication, she had been very finely investigated, it's been going on for years together. And he evaluated her, and he said, keep in touch with me. And we did hear, and she did connect to us too, and she said that she did recover. But that doesn't mean that we go ahead and act like a medical doctor and start treating all the sinus patients.
Thank you.
He is specially qualified. He's a medical doctor.
I think, he was also somebody who was, who claims that, yeah, Robin McKenzie would
Yes, he can't hear you.
be the person to be. Hello.
Yeah.
Yeah, ma'am. Another question was, hello.
Yes.
How do we rule out vertigo in the differential diagnosis? Is it more of a chemical nature?
Vertigo, we can get cervicogenic dizziness. And so, Devang, would you like to answer that question, since it is very closely to your case study?
Yeah, so according to me, I think vertigo, once again, a cervical spine or a mechanical thing can lead to vertigo. Once again, the rule applies same. You find out first the cause of the vertigo. If it is a mechanical, yes, they would definitely respond fantastically well to specific movement. If it is not a mechanical, you would, yes, you may refer those cases for further investigation and further management. So I think once again, it is a kind of a thing where we need to be quite specific. Like, is it a vertigo due to, once again, C1, C2, C3, or is it something else?
Mm. And so what we can very clearly see here is that as you do the repeated movement tests, you'll find that the dizziness is getting less and less and less with the directional preference. So that would tell us that this is a dizziness which would really be affected with our exercises.
Mm-hmm.
Okay, anything else?
Yeah, I think, ma'am, one last question. We would just take up one last question. That was, can headache be referred from suboccipital muscles or upper trapezius or the splenius capitis?
Once again, we've got to, not try to think, why would the muscle start giving pain? Now, if you are going to move the joint, or if you're going to be um, moving the spine, because that's where these muscles would be. If you're going to move the spine or move the joints there, and you find that the spasm of the muscle changes, the spasm is better, the symptoms are better. What's the cause of the pain? Is it the spasm? or is it something that's happening at the joint? So we need to really think in terms of evaluating a patient, not just fixing it up with muscles. Everything is not muscles, although we would like to believe it. And yes, in tension headaches, we know that there can be a forward head posture, and that can cause some amount of a spasm, and that can give rise to headaches. But once again, differentiating between tension headaches and a cervicogenic headache is also difficult. So what is going to tell us which of it is it? If it is a cervicogenic headache, which is going to be reduced or abolished with repeated movements or with positions, and we are getting a directional preference there, and it gets abolished immediately, and you also find that the spasm that is there in the muscle is lesser or gone, then we know that it's a cervicogenic headache, and it's the joint, the cervical joint, which needs to be moved, or we need to use static force there. Is that clear?
Yes, ma'am.
Thank you, ma'am.
So there's one question I can see here. Blood supply to the brain is a possible cause of a headache. I think the case study very clearly showed. Uh, yes, of course. And that's exactly the reason why we need to rule out a headache, rule out and do a differential diagnosis there. If you are going to go and look at a lot of research studies by Kerry et al., there are, of course, other authors too, but there are a lot of papers by Kerry et al. On carotid arteries, vertebral arteries. Go ahead and read it. It's going to change the way you look at a headache, because vascular factors can cause a headache. And we need to remember that before we put our hands on. Anything more?
Shall we?
All right.
Yeah, ma'am. Would like to once again thank Dr. Asha Menon, ma'am, and Dr. Devang Dharek for that
Thank you, ma'am. Was able to hear you, but not able to
knowledgeable
see you.
session
I don't know. There was some
today evening.
screen sharing problem from Dr. Hitesh Aroda's side. So was not able
No,
to
this
see you.
no. Screen
I'm not
sharing.
able to see you, ma'am, at all. Only
No,
able to hear you.
yes, 1 minute. The screen sharing was by me. The screen sharing
Ma'am,
was
but I was not able to see anything, ma'am. I
this.
was only able to hear you.
Didn't you see the slides? Because the screen sharing is from my end,
Ma'am, true, ma'am. I had to.
and the screen sharing was from Devang's end when he did the presentation. So, well, all that I could tell you is that maybe look at the YouTube that is being. So I did look in between. It was being seen on YouTube. So what you can do is probably have a look at the YouTube, and you could get the whole thing again.
Ma'am, yes, ma'am.
Okay,
Okay.
so probably it could be some connectivity, because I could see my screen over here. So at my end, I think it was seen.
Ma'am, able to see you only in the last 2 minutes just now. Before
Yeah.
that, I was able to see only Dr. Hitesh for some time. Otherwise, there was and the screen was totally empty from my.
No, it was, it should be
I was
some,
only able to hear you like a radio. Sorry to say.
right. So it was, the screen sharing was from my end. And so I was able to, what you could do is maybe go onto the YouTube and look at it.
Yes, ma'am. I will. I
All
will. I
right.
will. Right,
Okay.
ma'am.
Yeah.
Right. Thank you, ma'am. Thank you so
So
much.
thank you so much.
Thank you, Dr. Brijesh Kapoor. Thank you, Dr. Brijesh Kapoor,
Yeah.
for
Thank you. Thank you.
joining us.
But
And
I would have liked to see
I would
the
like to
video
thank
also
all the
because there
participants
was no
for
video
attending.
sharing. I don't know why
Sure.
there was no slide sharing from this.
Probably
Totally
you should.
Well, I
blank.
think
It's totally blank, ma'am. I had to go on YouTube and then see in between from this, but the hearing was double.
I think
So,
you need to look at your internet.
ma'am, it was okay all the time. I don't know. This is the first time it has happened like this. It has never happened before.
All right.
Right, ma'am. Thank you, ma'am. Thank you so much for your great knowledge
I think
sharing.
we
Yeah. Apologies to you if there's
Yeah,
anything from
no
our
problem,
end.
ma'am. Right, ma'am. Thank you, ma'am.
for all the participants, if you if you wish to connect to us, you all can mail the McKenzie Institute India on miindia@mckenzieinstitute.org. You can also follow us on Facebook and follow our videos on the on MI India YouTube link for further details of any further webinars and courses in India. Thank you.
Thank
Thank you
you
so
so
much.
much.
Thank you, ma'am. Thank you so much.
Thank you, Dr. Brijesh. Thank you,
Thank you,
Hitesh.
ma'am. Thank you so much.
Thank you, ma'am.
Thank
See
you,
you.
Devang. Thank you, Dr. Hitesh, Dr. Brijesh. Thank you so much. Thank you,
Thank you.
one and all participants.
Yeah,
I
ma'am.
think it's the participants that we need to really thank
Yes, ma'am. The
for being
participants have
here,
been very enthusiastic and very nice.
for
Thank you.
coming here in large numbers and hearing. Thank you so much. We've enjoyed having you with us. Thank you once again. And for any support, please feel free to email and we'll really get back to you. Thank you so much. Bye.
Thank you, ma'am.